Hello, and welcome to the Risk Adjustment Documentation and Coding Specialty Series on Oncology and Radiation Oncology. Today's agenda will include the Risk Adjustment Model, documentation review, cancer coding guidelines, and some examples. So, what is risk adjustment? Risk adjustment is a prospective payment model for your Medicare Advantage population. The model utilizes a patient's demographic, such as gender, age, disability, or how that patient aged into the plan, and diagnosis codes to predict costs for the following year. What are hierarchical condition categories, or HCCs for short? HCCs are a diagnosis grouping consisting of clinically related diagnosis codes that have similarly related projected costs. For example, diabetes with manifestations, diabetes with chronic kidney disease, neuropathy, or circulatory conditions all fall into the same HCC category. Why is risk adjustment so important? So, as we enter into value based care contracts, how effectively a provider documents a patient's health status will determine how much a payer will budget for the care of that patient for the following year. It really paints a picture of how sick or how healthy your patient population is. Payments are based on the highest degree of severity. So, HCC8 accounts for secondary cancer, acute leukemia, intrathoracic, intra-abdominal, and lymph nodes. HCC9 accounts for lung and upper GI, liver, gallbladder, pancreas. HCC10 accounts for lymphoma, connective tissues, bone, and nervous system. HCC11 accounts for colorectal, bladder, oral cavity, spleen, kidneys. HCC12 accounts for breast, prostate, eye, benign neoplasms such as the pituitary, and uncertain behaviors. This is why it's really important to document and code to the highest specificity because every diagnosis will fall into a specific HCC. CMS also takes into account disease interactions. So when you have a patient that's being treated for cancer by chemo drugs, they'll take into account the immune disorders such as neutropenia, graft host disease, pantocytopenia. It's important that if these conditions are related to the drugs that we identify and document the adverse effect and identify the drug related to the adverse effect. CMS has also implemented alternative payment condition counts for payment year 2021. So if you have a patient who has multiple chronic conditions and those conditions have relevance to your face-to-face encounter, that once they are documented, anything about any condition um, of 4 through 10 will be taken into account for that patient's risk profile, hence the need to document and capture all chronic conditions at the time of face-to-face encounter. Documentation matters. We can't stress this enough. Lack of documentation will leave active diagnosis codes out of that patient's risk profile and has negative impact across all risk adjustment methodologies or value-based care methodologies. Misdiagnosis codes are not factored into forecasting for medical costs for the following year, can affect the patient's care by leaving them out of disease management programs. So our initiative really focuses on educating the providers to document and accurately code all conditions that affect management of that patient. Educating the provider on documenting at a condition level versus specific initiative will really support accuracy for all payment methodologies. Improving documentation through specificity and clarity will really identify the time spent with your patient. Documentation for supporting codes reported. So, generalized statements within a progress note are not sufficient to substantiate the assessment and plan of diagnosis. For example, 64-year-old man with history of Geist. He is on Stavara since November 2019 with stable disease. Patient's chest pain is not related to Stavara. Cardiology workup pending. Tropion slightly elevated. Best practice would be 64-year-old man diagnosed with primary GEIST on 11/19 and metastatic hepatic malignancy on 1/21. Currently on Stevara for GEIST with no further progression of disease. Patient's chest pain is not related to the medication. Cardiology workup is pending and tropion slightly elevated. A comprehensive assessment with plan for each condition is best practice for compliant and accurate code capture. It is also important to link etiology and manifestations when defining disease processes during an encounter. Language is important, especially when it comes to cancer coding. History versus active. So, history of is really from a provider's perspective. History, from a coder's perspective, means historic, no longer active. Utilize phrases to reflect current treatment for a current condition. So, a patient with breast cancer on adjuvant therapy continue Nerlings or anastrozole. Prostate cancer, watchful wait, will monitor PSAs. Cannot stress enough, language in your progress note is extremely crucial to tell your patient's story. Personally, I like her story, but it's really not correct English, but I am partial. So we have some more documentation and coding tips. Document relevant lab and diagnostic results in your progress notes. It's very important to pull in any. We know you're reviewing labs, we know you're reviewing diagnostics. So, in doing so, pulling them into your progress note will really, again, explain that patient's health status. Unspecified codes should really only be utilized during testing and the determining phase. We realize that there are times when you have to use an unspecified code, but once a diagnosis has been established, unspecified should not be documented or coded. Do not code diagnosis documented as probable, likely, suspected, or questionable, as we have a whole section on signs and symptoms in the ICD-10 coding book. Do not code conditions that were previously treated and no longer exist. We would code those as history, and I do realize that a lot of providers don't like to take the active cancer code out of their drop down because it, for some reason, drops it down to not as important when you're utilizing the drop down menu. But it's really important that if the patient is no longer under treatment, no longer being on the chemo or radiation, that code be a history code. Code all documented conditions that coexist at the time of the encounter or visit and require or affect patient care. So a patient with chronic conditions such as diabetes and they are under radiation oncology treatment, we know that radiation oncology really affects the skin. So diabetes is very important to document when you're treating that patient, because if they get an open wound from treatment, the diabetes is gonna really not help with wound closure, right? So again, this is why it's very important that we are capturing those chronic conditions at the time of face-to-face encounter, even though the specialist is not following for those chronic conditions. EMR reminders. When using pre-populated templates, it's very important that you update your template at the time or on that data service to reflect any changes in your progress note. If you're copying a note from a previous visit, please update any information brought forward to reflect any changes since the previous visit. We have an electronic EMR. Lots of times things are copy and pasted to the next visit. So it's very important that you document it for that data service, that it was reviewed, and that you sign off on that progress note. Problem lists should be reviewed and updated at each visit. Should indicate review was performed by a physician or a physician extender. Should only include conditions actively being treated under the problem list. Problems should be removed or resolved if a more specific diagnosis code has been added to the list. For example, a patient who has uncomplicated diabetes now has diabetes with neuropathy. So you would take the uncomplicated diabetes and put it in the past medical history and keep the diabetes with neuropathy under the problem list. Resolved diagnosis codes, as indicated, should be moved to past medical history or changed to a history code if they no longer have impact or are not under current care or treatment. Medication lists, really important, should be reviewed and reconciled at each visit. Should indicate review was performed by a physician or a physician extender. Many times we'll see a medication on the medication list, and they're used for treatment for multiple conditions. So if you have a medication that is used for multiple conditions, it is very important that you document which condition that medication is utilized for, as to be as crystal clear as possible in your progress note. And of course, with electronic EMR, you need your provider's signature, their credentials, and the date the note was signed to be valid for risk adjustment. Well, we have an EMR and we think that, you can't bypass that step, but I have done chart reviews where I have seen that step bypassed and billed out to the payer. So it's very important that we close those progress notes once we are done documenting and assessing that patient. We use Tamper when we're doing risk adjustment chart reviews. And so we have to ensure that at least one element of Tamper is documented for each coded condition. So T for treat, with medications, therapy, or any other treatments. A is assess, the diagnosis, the improvement, the worsening, or order testing. M for monitor, medication, signs and symptoms, response to treatment, plan, place a plan into effect for the treatment of that diagnosis, evaluate with your exam, your test results, or your record review, and also are referred to a specialist. Commonly missed chronic conditions. So even if the chronic conditions are stable, these conditions should be assessed because they do have relevance to your face-to-face encounter, and they do have impact on treatment. So lots of times a patient will have gastric cancer and they have an ostomy. We have to capture that ostomy status as long as it's relevant and as long as it's still active. Again, diabetes and any manifestations. We know that diabetes can affect that patient's entire health status. So if diabetes is exacerbated by the treatment or the cancer, it's important that we capture it. When a patient is diagnosed with cancer, lots of times they'll have a depression. So capturing the depression to the highest specificity with depression with the episode of care and severity is very important when you're coding and documenting for depression. Morbid obesity. Lots of times a patient is under treatment for chemo and they start to gain weight. So capturing that patient's BMI and documenting the morbid obesity is very important. Congestive heart failure lots of times can be contributed to the chemo drugs. So if it's actually assessed and found, or if the patient has a history of congestive heart failure, making sure that we're documenting and coding it at the time of the encounter is very important as well. So here are some additional cancer coding guidelines. So when a primary malignancy has been previously excised or eradicated from its site, there is no further treatment directed to that site, and there is no evidence of primary existing malignancy, then we should utilize the personal history of that neoplasm. To code for an active diagnosis of cancer, we should have surgery date, chemotherapy treatment, radiation treatment, or adjuvant hormonal therapies. If a patient opts out for no treatment towards the malignancy or treatment is contraindicated, the provider must document it as such in each encounter so that the appropriate active cancer code can be assigned. If a patient is coming up for a follow-up encounter after treatment is completed, then we should use a diagnosis code from the Z08 category and also the personal history of the malignant neoplasm in, for correct coding and sequencing. So, cancer documentation. Documentation for accurate code assignment should include the date the cancer was diagnosed, the type of neoplasm, the anatomical site, whether it is a primary or a secondary site, surgical information if they've had it surgically removed, and what treatment that patient is currently under or going to be starting for that cancer. We should also document any complications related to the neoplasm and or treatment, such as anemia. Now, I will say that some of these conditions do not risk adjust, but again, we want to tell the full story of that patient. So whether it risk adjusts or not, we want to make sure that we are painting an accurate picture of your patient. So anemia due to the malignancy or due to the treatment of the malignancy, right? Dehydration related to chemo, radiation, or just the cancer itself. Any pathological fractures um, need to be documented with the additional subcategory code from M84.5 should be captured to identify the specific site of the fracture, along with the neoplasm, which identifies the specific cancer. Malignant neoplasms or transplanted organs. This is very important. Lots of times we cannot tell as coders what came first, the chicken or the egg. Did the patient have cancer and then got a transplant? Or did the patient have a transplant and then got the cancer? So there's really specific coding guidelines to those situations that are explained here. Assign the appropriate code first from category T86, which is the transplant, complications of transplanted organs, followed by C80.2, malignant neoplasm associated with transplanted organ. So if you need additional help with that, we're definitely here to help. If you want to have a chart review to make sure that you're doing the correct documentation and coding to the highest specificity, again, we are also here as a risk coding team to help with that. Additional complications would be protein calorie malnutrition that can be associated with cancer or any other diseases and can cause increased mortality. Supporting documentation for protein calorie malnutrition, involuntary weight loss, greater than 10% of the usual body weight, serum albumin less than 3.5, food intake severely decreased, and a BMI of less than 18.9, apparent muscle wasting, and fat loss. So your assessment and plan should really indicate the malnutrition severity and the treatment plan. Document and report diagnosis for any associated conditions. So here are some codes. So E44.1, which is mild malnutrition. E44.0, moderate malnutrition. E43, severe malnutrition. And of course, cachexia, R64, really have high impact on your risk adjustment. and that patient's profile. So now we come to some examples. Now, this patient came in for a PCP visit. And I know you're saying, oh, we're the specialists. Why would we be concerned about a PCP visit? Our PCPs really look to the specialists for the correct documentation and coding specificity. And so while they're not very knowledgeable, maybe in oncology and radon, they look to the oncologist and the radiation oncologist to pick the appropriate codes. Now, this patient has malignant neoplasm overlapping site of left female breast, unspecified estrogen receptor status. They also have malignant neoplasm of colon, unspecified part of colon. It's possible that it's in the patient's medical record, but for this PCP visit, patient provider is not indicating if one is primary. It's possible that they both can be primary, but we don't have a time frame of when they took place. We don't know what's going on with any treatment. So the note is really not specific. Again, our PCPs look towards the specialist for proper documentation and correct coding. So it's very important that as a specialist, we are doing our part, right? Patient is here for metastatic to the lung follow-up visit. So, bullet number one, hepatocellular carcinoma metastatic to lung, unspecified laterality. These are the diagnosis codes that were actually on the claim. I must point out that when you document in your record, that it is equally important to choose the correct diagnosis code, because that diagnosis code is going to drop to the claim. Now, I understand, providers say, oh, we're not coders, how are we supposed to pick the correct code? Again, you have your risk coding team that you can reach out to for any assistance on coding. And so, of course, they picked the C78.00, which is metastatic lung, C22.0, which was the liver cell cancer. They also picked D12.6, which was benign neoplasm of the colon. Z94.4, which was a liver transplant, and K21.9, which was GERD. In the note, you'll see that CAT scan guided biopsy of the pulmonary nodule was performed, and the right upper lobe is consistent with metastatic hepatocellular carcinoma. So why we have unspecified laterality to the lung, I don't know. But I know as a coder that we cannot utilize that CAT scan. The provider needs to pull that specificity into their progress note. Now, bullet number 3, liver transplant in 2017. Really doesn't tell me, again, chicken or the egg. Did the liver transplant happen prior to the liver cancer, or did the liver cancer happen prior to the liver transplant? So again, documentation and specificity is very important. So patient had elevated LFTs due to alcohol abuse and relapse. Alcohol abuse and relapse is very relevant to that liver. So that diagnosis code was missed in the documentation and on the claim. So again, this is a chronic condition that has relevance to your patient being treated for liver, right? Okay. And then the patient has new thrombocytopenia. Again, documented in the note, but the code was not utilized or chosen. So it didn't go out on the claim. Very important. So you can document to that, document all day. That's great. We love the documentation. Once we do a chart review, we'll see it. But it's also equally important to make sure that we're picking the diagnosis codes and that they're dropping to the claim. Because if they don't get out to the payer, then the payer doesn't know how sick your patient population is. And that's what we're finding, that lots of time the diagnosis code doesn't drop to the claim, and that just might be a billing issue, or just missed in its entirety. So again, not only is your documentation important, but also your code capture is important. Page 22. So patient comes back for a follow-up oncology visit, right? 66-year-old female with non-small cell lung cancer and chest wall pain. So the plan: non-small cell lung cancer, no sign of reoccurrence at this time, will return back in 4 months. Well, unfortunately, the diagnosis that was chosen for this claim was an active lung cancer code. So while the documentation states no signs of reoccurrence, as a coder and an auditor, I can look at this and say, all right, so now I have to reach out to the payer and get this active diagnosis code out of this patient's risk profile, because it clearly indicates no signs of reoccurrence. And in this case, the doctor should have utilized the history code. So this is a rad-onc follow-up visit. Patient returns for a routine follow-up visit, now approximately 2.5 years after completion of right breast radiation therapy following excision and sentinel node excision for stage 1A invasive ductal carcinoma of the right breast. So this is a great note because it really states the site, when the patient was initially diagnosed, patient completed treatment, the surgery that was performed, and no evidence of disease, no evidence of recurrent disease. So this was a great oncology note. And again, it really speaks to, okay, the patient no longer has cancer, no recurrence. History code was utilized on the claim, so that was a win-win. So we have some additional oncology and radiation oncology provider tips. So providers may document history of leukemia when the status of remission is appropriate. Secondary presentations have significant HCC risk adjustment impact. Providers generally do not realize this and opt to document only the primary disease. They sometimes choose a secondary lung term within a drop-down menu and define a bony mets from lung cancer rather than documenting the secondary involvement of bone. So again, it's really important that if the patient has a primary cancer and then a secondary cancer, that your documentation reflect that. Bone marrow transplants is one of the conditions that are frequently overlooked and not documented or coded, but have significant HCC impact. So if you have a patient with a bone marrow transplant, it's very important that we capture that status code. Codes C80.0 disseminated malignant neoplasm or unspecified, and C80.1 malignant neoplasm should rarely be assigned. These codes should be used in place of assigning codes for the primary site and all known secondary sites as appropriate. Cachexia, very important, is often present in patients with stage 4. If documented and coded, this diagnosis can prove significant HCC impact. Really works with the protein calorie malnutrition. A patient who's cachexic is very important to document, and of course choose the appropriate code that reflects that documentation. So, key takeaways: review and update problem lists at each visit. Include problem and medication lists in your visit note to support active conditions. Document all current chronic conditions at least once a year or at the time of your face-to-face encounter when they have relevance. Document and code conditions to the highest degree of specificity. So, a patient with diabetes and manifestations, let's not code E11.9, uncomplicated diabetes, when they do have manifestations. Document all conditions which have impact to your medical decision making. Assessment and plan should clearly indicate treatment plan for each condition. Let's also remember, or you might want to talk to your billing team when you're documenting and choosing diagnosis codes to make sure that those diagnosis codes are dropping to the claim. Just might take a little bit of work with your billing team or your billing vendor to make sure that your codes are going over to the payers, because you can document all day, you can choose codes all day, but if they're not dropping to the claim, they are not getting to your payer. So that is the end of this specialty webinar. Thank you very much. And if you have any questions or concerns, please email us at icpcommunications@hcchealth.org. As always, we are an extension of your practice and are here to help with any risk coding, documentation, or coding issues. Thank you very much and have a great day.